Good morning. The subcommittee will come to order. Thank you all for joining us this morning. You know, every dollar hospitals spend on inaccurate Medicare audits and appeals or dollars lost should have been used to care for seniors. We're here to discuss the problems facing hospitals today, but also to find solutions that bring sense to our Medicare program and improve care for America's seniors. Today's hearings will examine hospital issues, including those related to CMS's Two Midnights policy, as well as audits and appeals. This is a bipartisan concern shared by many different stakeholders, the Medicare program itself, and lawmakers on this committee. In order to understand why CMS chose to pursue a Two Midnights policy, we have to first explore the events leading up to the policy. After we review those events in today's hearing, Congress will be able to make an informed judgment about the merits of the policy and potentially pursue alternative solutions. Our first panel will educate us on the different aspects of inpatient and outpatient payments and services for hospitals. If we want behavior to change and improve outcomes, we need to change the incentives. Our second panel will feature national experts commenting on how federal laws affect everyday medical practice. We'll be hearing perspectives from across the spectrum, providers, auditors, researchers, and beneficiary advocates. As I've talked with stakeholders about current issues in the Medicare program, the Two Midnights policy comes up over and over again. In listening to a variety of different perspectives, I've come to understand the following. There are misaligned incentives in CMS's inpatient and outpatient payment systems. But hospitals are not doing anything wrong. They're simply responding to the incentives. No matter if a service is inpatient or outpatient, hospitals still use the same equipment and the same medical staff to deliver care. Yet there are two vastly different payment systems, and the systems don't relate to each other in any way. They're based on different coding rubrics, and they pay for different things. And often this is all decided after doctors have provided care. Take, for example, reimbursement for medical education. If the service is billed inpatient, a hospital qualifies for an extra medical education payment. However, if the same service is billed outpatient, the hospital doesn't receive any medical education money. So if you're a large teaching hospital and you could bill under either payment system, why would you ever submit the bill for anything other than inpatient reimbursement? It's all about the underlying incentives. Now let's examine the next piece of the puzzle, auditing. I've heard from hospitals that audits are causing undue burden. I've heard from recovery audit contractors, or RACs as they're known, that they're simply responding to what CMS has defined as improper payments. Their emphasis on short hospital stays is due to, well, you guessed it, the underlying incentives. RACs are able to keep a percentage of any improper overpayments they recoup. Prior to the Two Midnight standard, there were no definitive rules governing which payment system was correct for short stays. RACs are an important program integrity tool. I think we can all agree. They're focusing on a legitimate discrepancy of Medicare payment. They, too, are responding to the incentives. Although an important tool, auditing also causes unintended behavior changes. We will hear from several of our witnesses today that around the same time the RAC short-stay audits were in full swing, there's also an unprecedented spike in outpatient observation services. Observation is meant to be a temporary tool, allowing clinicians to closely monitor patients without using full-blown inpatient hospital resources. However, observation services are now being used as a tool to avoid certain adverse effects, including RAC audits, in some cases avoiding readmission penalties. The saga continues when we turn to the appeals process. Hospitals disagree with RAC audit denials for short stays. As a result, they appeal the decision. Hospitals have found a high level of success at overturning RAC denials at the administrative law judge, or ALJ, level. Same theme, responding to incentives. ALJ equals more likely to have an appeal overturned, so appeal every time. So much activity at the ALJ level has led to an extensive backlog of appeals. Earlier this year, the Obama administration suspended the assignment of new appeals at the ALJ level. Again, we see unintended consequences, denying providers their basic due process rights, occurring as a result of poor incentives. We intended to have a witness from the Department of Health and Human Services here today to testify on behalf of the Medicare appeals process. Unfortunately, Chief LJ Nancy Griswold was unable to join us, but HHS is committed to briefing the Ways and Means member, bipartisan manner, on this important topic. At the conclusion of today's story lies the heart of the issue, the two midnights policy. In response to the inpatient-outpatient payment predicament, RAC audits, increase in observation stays, and backlog of appeals, CMS took its best shot at a solution, two midnights. Today we'll hear from all of our witnesses on whether the two midnight solution is solving all or any of the various problems identified in this tale. I commend my colleagues on this committee, members on both sides of the aisle, who've introduced bills that pursue different alternatives to the two midnights policy. My colleague, Mr. Gerlach, along with the original co-sponsors, Mr. Crowley, Mr. Reed, Mr. Roscom, Mr. Kine, have offered a sound proposal for our committee to work from. Before I recognize Ranking Member Dr. McDermott for the purposes of an opening statement, I ask, as always, unanimous consent that all members' written statements be included in the record. Without objection, so ordered. I now recognize Ranking Member Dr. McDermott for his opening statement.